this talk actually builds on a prior e-learning event that happened last fall with Julia Barham, a colleague of mine, and Dr. Brian Martins. And so if you missed that previous event, I encourage you to look it up on the CEDN website and review that as well. So the first talk this morning is going to focus on assessing cardiovascular medications in older adults. So just a quick overview of what we're going to be talking about this morning. I'll provide some background on this topic and introduce our case patient and some questions for you to keep in mind as we review the material. We'll talk then about medications for atrial fibrillation, heart failure, high cholesterol, high blood pressure, and then finally we'll go back to the case and resolve some of the issues we identified earlier. So some key messages that I hope you'll take away from the presentation this morning. One really important thing to note is that medication requirements often change with age. And this is something that we as healthcare providers, I think, are quite well aware of, but we don't necessarily do a good job of communicating that with patients. So often when we start them on high blood pressure or medications for diabetes, we give them the impression that they'll be on it forever and they need it forever. And that's not necessarily always the case. So both the tolerability and the effectiveness of medications can change with age, either for better or for worse, as we'll talk about more in more detail soon. As well, important to note that age is an important risk factor for both cardiovascular events as well as adverse drug reactions. And so finding the balance between these two issues is why dealing with cardiovascular and diabetes medications consumes a significant portion of my time on the geriatrics unit. And I'm sure you run into these dilemmas in your daily practice often as well. And then finally, I want to make the distinction between chronological age versus physiological age. So I'm sure we're all familiar with relatively young older adults, 55, 60, that have a lot of medical comorbidities and are what we would classify as being very frail, versus very healthy 85 to 90-year-olds who are still fit and able to do the things that they want to do with no issues whatsoever. So to illustrate this point, Mr. Ed Whitlock is 80, and he set a new world record at the Toronto Waterfront Marathon a couple years ago. He ran the marathon in 3 hours and 15 minutes. So to put that into context, if I ran a marathon in 3 hours and 15 minutes, I would throw the biggest party known to man, and I would also qualify to run the Boston, the most prestigious marathon ever. So again, age is on a continuum, and so the concepts that we're discussing here apply to frail older adults, whether they're 60, 80, or 90, and not to people like Mr. Ed Whitlock, who still should be treated to more aggressive blood pressure and cholesterol targets that we would for healthier, younger adults. So medication issues in older adults present several unique challenges for medications. So as we age, we tend to accumulate a lot of medical comorbidities. And along with that, a lot of medications to treat these various medical comorbidities. And so that predisposes patients to drug-drug and drug-disease interactions that are important to be aware of. As well, medication response changes with age, as I've already alluded to. So both elimination of drugs and in particular renal function declines with age. And so many medications are eliminated by the kidneys, and so that predisposes patients to adverse drug effects from that perspective. As well, older adults tend to be more susceptible to the CNS adverse effects of medications like drowsiness and dizziness, which can impair balance and predispose to falls. So we've already kind of talked about the increased risk of adverse drug reactions, and there are several adherence issues that are unique to older adults. So changes in vision and hearing can make it difficult to adhere with a medication as it was originally intended to be taken. So we all know the font size on the vials you get from the pharmacy is not user-friendly for an older adult with any degree of visual impairment. Opening vials or bubble packs requires a certain degree of manual dexterity that may become an issue with age. And as well, changes in hearing or cognition may make the ability to understand directions as said to a patient challenging as well. And finally, older adults may have changing priorities. So in terms of preventing cardiovascular events 10 years, 15 years down the line, that may not be as relevant for an 85-year-old older adult as their day-to-day quality of life. And so finding the balance between preventing future events and maintaining quality of life in the moment at an acceptable level for the patient is a challenge. But it's also partly why I love working in geriatrics, because there is so much opportunity to work with patients to figure out what's important to them and then tailor their medications to meet their goals. There's no cookbook approaches to geriatric medicine. And then finally, in geriatrics, there's a real lack of evidence-based medicine. So most of the patients that I see and probably that you see in your practice are not like Mr. Ed Whitlock out running their marathons. We tend to see the frailer, older adults with a lot of medical comorbidities that would generally be excluded from all clinical trials we have that demonstrate cardiovascular effectiveness of medications. And so that's important to keep in mind as well. We don't have good evidence to support most of these therapies in frail older adults like we do in younger, healthier adults. So just to outline some resources that are really helpful for assessing medications in older adults. LexiComp is kind of my go-to for drug dosing information on side effects and drug interactions, and those kind of basic drug fact type information. The Geriatric files is a newer version of the RX files, and it was developed specifically as a reference on medication therapy in older adults. If you're not familiar with it, it's different from the regular RX files charts in that it takes a very disease-specific approach to medication issues. So you can look up a topic like atrial fibrillation, and the Geriatric files will lay out an approach to atrial fibrillation in older adults, including preferred medications as well as medications to avoid. And so it's a very helpful reference. Both of my presentations today are using materials from the Geriatric files, and I would encourage you, if you're not familiar with it, to check it out. rxfiles.ca also has a lot of helpful resources. They have newsletters and question and answers on important topics. And then as well, if you go to the home tab, the long-term care section has a lot of really good resources, again, specific to medication management in older adults. Other resources, so both the 2015 Beers criteria and the STOP criteria outline medications that may have more risk than benefit, specifically in older adults. And so if you work a lot with older adults, it's worthwhile to familiarize yourself with what medications are on those lists and what maybe should be avoided. And where the Geriatric files, I think, really comes in there is that the Geriatric files then will outline alternatives to these potentially inappropriate medications. So rather than just telling you not to use something, they give you something that you can use instead. And so that's very helpful as well. As well, our second speaker, Karen Jensen, is going to be talking to you about MedSask. And MedSask is an excellent resource if you have drug information type questions. We at the RX Files use them a lot. I use them a lot in my practice to look into medication-specific issues, and they give very thorough, detailed answers. All right, so now I'd like to introduce our patient case, Mr. H.N. So he's a 93-year-old man, and he was hospitalized for a hip fracture following a fall. So he got up at night to go to the bathroom and felt dizzy and suffered a fall. Fortunately, he was wearing an emergency response system that activated when he fell, and the paramedics were called, and he was brought to hospital for treatment. Medical history, so he has a very substantial cardiovascular history. He had MI in 1998. He has atrial fibrillation and heart failure. His ejection fraction's around 25%, so fairly low. He had a TIA a couple years ago. He has hypertension, diabetes. His A1C is about 7.5%. He has a history of spinal stenosis, benign prostatic hypertrophy, and urinary urgency. And he's had several falls over the last year, although this is the first one that resulted in an injury. His sitting blood pressure, since he's been in hospital, has been averaging around 95 on 51, and his heart rate is around 53. His creatinine clearance, when you calculate it using the Cockcroft-Gault equation, is around 33 mils per minute, so he definitely has some kidney impairment as well. So for medications, again, he's on his fair share. He's on warfarin and aspirin. He's also on bisoprolol, 7.5 milligrams a day, And digoxin, that's a typo, sorry, that should be 0.125 milligrams a day. Ramipril, 2.5 milligrams a day. He's on a nitroglycerin 0.8 patch that he applies when he wakes up in the morning and takes off before bed. He's on furosemide 40 milligrams in the morning and 20 milligrams at noon. Atorvastatin 20 milligrams a day. Gabapentin 300 milligrams 3 times a day for his spinal stenosis. And Tylenol arthritis as needed. And vitamin D 1,000 units a day. So giving you a second to digest that, I'm sure there are several issues that right off the cuff you're kind of wondering about. So these were things that I had picked out that I'd wanted to address with Mr. HN while he was in hospital. So for his atrial fibrillation, first of all, does he require warfarin, aspirin, or both? Is the combination appropriate for him? Would he perhaps be better off on a new oral anticoagulant that doesn't require ongoing daily monitoring? And does he need both the bisoprolol and the digoxin to control his heart rate? For heart failure, again, does he need the digoxin at all? And if so, we should probably check a level to make sure the dose is safe and appropriate for him. Hypertension, so is the combination of medications that he's on appropriate? And again, his blood pressure is quite low as of right now, so how low is too low, and should we be concerned about that? And then finally, for his cholesterol, at 93, is a statin still appropriate for him? Is that a necessary medication that he needs to be worrying about every day? So I want you to kind of keep those issues in mind as we go through the presentation or the slides on the various topics, and then we'll come back to Mr. HN at the end of the presentation. So we're going to start by talking about atrial fibrillation, which is a significant problem in older adults. Approximately 1 in every 5 strokes are due to atrial fibrillation, and strokes from atrial fibrillation are more than twice as likely as ischemic strokes to result in permanent death or disability. So certainly a really important issue to address in older adults. So the incidence of atrial fibrillation increases with age. Approximately 10% of patients 80 years of age and over will have AFib, so a very common medical condition in clinical practice. And advanced age increases the risk of both stroke as well as major bleeds. So again, putting patients in kind of a rock versus hard place dilemma in terms of managing their bleed risk as well as their stroke risk. So it's important to try to find the balance there, and we'll talk about how to do that. We know from several studies that advanced age is a deterrent to anticoagulation. So off the cuff, clinicians tend to overestimate the bleed risk for a given patient and then underestimate the potential benefit of anticoagulation. Sorry, my clicker was a little bit late there. As well, the adherence required to warfarin therapy and the ongoing monitoring requirements for the INR can also be a deterrent to anticoagulation, particularly in patients that have some cognitive impairment or limited mobility, making it challenging to get to the lab and then follow instructions for changing warfarin doses. And again, underestimation of the overall benefit of anticoagulation. So what is the evidence for anticoagulation in older adults? There was a study called the BAFTA that was published in 2007, and it looked at warfarin versus aspirin specifically in older adults, so 75 years of age and over for atrial fibrillation. And most of these patients had a moderate risk of stroke, so CHADS 2 score of 1 or 2. Important exclusions, obviously patients with a lot of bleed risk issues. But they did find that warfarin significantly reduced the risk of strokes. They needed to treat 21 patients with warfarin over aspirin for 2.5 years to prevent 1 stroke. So that's a very significant clinical benefit of warfarin over aspirin. Interestingly, in this study, they also found no significant difference in major bleed rates, which is not what we would expect based on other studies. Being that it was a clinical trial, patients were probably followed up a lot more closely than they are in regular clinical practice. And again, the exclusion criteria that is listed is probably part of that as well. So patients with a lot of bleed risks would have been excluded from that study. So from other studies, we know that the risk of warfarin versus aspirin, approximately 250 patients need to be treated with warfarin over aspirin to cause 1 intracranial hemorrhage, and this is over about 3 years as well. and approximately 100 patients to cause one major bleed. So warfarin is associated with more both major bleeds and intracranial hemorrhage than warfarin, but given the substantial benefit in terms of reducing potentially disabling strokes, warfarin should still be the go-to for most older adults. So when you're looking at deciding, considering anticoagulation for an older adult with AFib, first, is there an indication? And we'll talk about how to decide that. Is there a high risk of bleeding or some other contraindication to anticoagulation? Will the patient be able to adhere to the therapy as well as the monitoring that's required? And then finally, what are the patient and family preferences around anticoagulation? And again, that will be a recurring theme throughout the discussion today. Patient and family preferences, particularly later in life, trump guideline recommendations and all of that sort of thing. But as healthcare providers, we're also obligated to give patients the right information to help inform those decisions. So first of all, is there an indication for anticoagulation? And to determine this, we need to calculate a CHADS-2 score. So adding up 1 point for each of congestive heart failure, hypertension, age 75 and over, and diabetes. And then patients that have a history of stroke or TIA would get 2 points. And so is anticoagulation indicated? So a CHADS-2 score of 1 or more says that yes, anticoagulation is indicated. And so we're just going to go back for a second. So because age 75 and over gives you a point on the CHADS score, essentially all older adults should be anticoagulated based on indication alone. So that's important to note. The second step is to determine the patient's bleed risk. And the HAS-BLED score is the best validated tool for assessing the patient's risk of having a major bleed on anticoagulation for AFib. So the HAS-BLED score looks at uncontrolled hypertension, so a systolic blood pressure of more than 160, abnormal renal or liver function, and specifically a serum creatinine of more than 200 micromoles per liter, a history of stroke, a bleeding history or predisposition, a patient that has labile INRs, so less than 60% time in therapeutic range over the preceding couple months, elderly, age greater than 65 gets a point, and then other drugs that a patient may be taking that could increase bleed risk. So specifically aspirin, clopidogrel, or non-steroidal anti-inflammatories like ibuprofen or naproxen. And so you'd add up 1 point for each of these risk factors. And it's recommended to be cautious with anticoagulation if the patient's HAS-BLED score is more than 3. And what essentially the first step is in that case is to look at altering any modifiable risk factors for bleed that's on the HAS-BLED score. So getting a patient's blood pressure under control so it's less than that 160 cutoff, looking at reevaluating the other drugs that they're taking that could increase bleed risk to help get that bleed risk down. But if a patient's HAS-BLED score is over 3 for non-modifiable risk factors, it's still not a contraindication, but you'd probably want to be extra careful and certainly have that discussion with the family about potential risks associated with anticoagulation. And some patients will place a higher value on preventing a potentially disabling stroke, and some patients will be more concerned with the possibility of bleeding, and that's an individual decision. So you'll notice that fall risk is not on the HAS-BLED score, and there's a reason for that. So studies have found that a patient would actually need to fall approximately 300 times a year for fall risk to outweigh the benefit of anticoagulation. So generally speaking, fall risk is not a deterrent to anticoagulation, although certainly you'd want to reevaluate the reasons for falls and try to minimize those as much as possible. But again, clinicians tend to, off the cuff, overestimate fall risk as a bleed risk factor for anticoagulation compared to what the evidence says. And so that's important to be aware of as well. And finally, the combination of warfarin and aspirin. So you'll recall Mr. HN is on both warfarin and aspirin, and is this necessary? So we know that the combination of warfarin and aspirin is appropriate for patients that have both atrial fibrillation and a history of an MI for 1 year. So 1 year post-MI, they should be on the combination. And thereafter, warfarin alone is appropriate. And so for those types of patients, you want to really reevaluate whether they should be on that daily aspirin. Daily aspirin significantly increases the risk of bleeds in older adults on warfarin. And so look to discontinue that wherever possible. Warfarin plus aspirin for atrial fibrillation is on the stop criteria, so it's been noted by some of these criteria as being potentially inappropriate in older adults because it does increase the risk of a bleed without offering any additional benefit in terms of stroke or heart attack reduction. So that's something to reevaluate when you see patients on both. Why are they on both? How long has it been since they had any kind of cardiovascular event? And then looking at reevaluating whether or not both are really needed. So now to talk a little bit about the direct oral anticoagulants. So these came on the market about 6 years ago. That includes dabigatran, rivaroxaban, and apixaban. And so they were developed as alternatives to warfarin for some of the monitoring issues that we've already identified. So some advantages of the direct oral anticoagulants over warfarin. So they have at least as good of efficacy, and specifically apixaban and the higher dose of dabigatran were actually shown to be superior to warfarin in terms of stroke risk reduction in AFib. They result in less intracranial hemorrhages than warfarin, with a fairly high number needed to treat, but still could be significant for some patients. They don't need INR monitoring, which is one of the big draws toward the new anticoagulants. The hassle of INR monitoring and the constant dose adjustments can make these agents very attractive. And then finally, they have fewer food and drug interactions than warfarin, which is beneficial as well. Disadvantages, so certainly cost. They're newer drugs and they're quite expensive, and particularly if a patient doesn't have coverage. And so the drug plan will only cover one of the newer agents if a patient has an intolerance to warfarin or labile INRs on warfarin, so inability to control that INR within the appropriate range. At least 60% of the time is the cutoff. Dabigatran and rivaroxaban are associated with more GI bleeds than warfarin, although apixaban was shown to be similar. We don't have any long-term safety data. Again, they're newer drugs, so we just know less about side effects and things down the road. A real disadvantage in older adults is that you need to be really cautious in using them with renal impairment. And so generally, patients with a creatinine clearance of less than 30 are not candidates for the new oral anticoagulants. And then finally, there's no antidote, so there's no way to reverse the anticoagulation if the patient has an acute major bleeding event. With the exception that just within the last few weeks, Praxbind, which is the antidote for dabigatran, has been approved and available in Canada. And so now there is an antidote for dabigatran, and probably soon there will be antidotes for the others available as well. So when should we look at switching anticoagulants from warfarin to one of the newer agents? So I would look at changing from warfarin to one of the new direct oral anticoagulants in a patient that has difficult to control INRs on warfarin. So if their INR is constantly fluctuating between high and low, they're at fluctuating risk of increased having a bleed versus increased having a stroke. And so those patients are likely better off on one of the newer agents that has a more predictable response. As well, patients that are unable to get to the lab for INR testing or to have any kind of mobile lab service come to their home, again, the newer anticoagulants are a better alternative because they don't require that monitoring. Warfarin is preferred over the newer agents, again in kidney dysfunction like we already talked about, and patients with mechanical heart valves or valvular atrial fibrillation because the newer agents have not been tested and shown to be effective in that instance. So those patients should remain on warfarin as well. In terms of which of the direct oral anticoagulants to choose, generally speaking, dabigatran is my last choice. It's very highly renally eliminated and causes a lot of GI upset as a side effect. And so generally speaking, I wouldn't choose that one, especially for older adults. It's actually on the Beers list if patients are over 75. Rivaroxaban has the potential advantage of once daily dosing, but usually I would probably choose apixaban. It has the best safety data so far, so it doesn't increase the risk of a GI bleed relative to warfarin like the other two. And it's also the best choice when renal function is borderline because it's the least renally eliminated of the direct oral anticoagulants. although it does require dose adjustment if patients have a lot of kidney dysfunction and low body weight or advanced age, which is important to be aware of. So now we've discussed managing stroke risk with atrial fibrillation, and we're going to move on to talking briefly about the atrial fibrillation itself, so rate control versus rhythm control and what's preferable. So generally speaking, rate control is the preferred management strategy for atrial fibrillation in patients 65 and over versus trying to convert them back to normal sinus rhythm. And this is because the drugs that are used to restore or maintain normal sinus rhythm tend to be really poorly tolerated in older adults. So things like amiodarone or sotalol, generally we want to avoid those if at all possible. And older adults usually do quite well with rate control. So there are 3 different medication classes that are available for rate control. Beta blockers are probably most commonly used because they're also the go-to choice if a patient has concurrent coronary artery disease or heart failure, which are really common comorbidities in atrial fibrillation. The non-dihydropyridine calcium channel blockers are also effective for rate control in atrial fibrillation. And so this refers specifically to diltiazem and verapamil. So those are the 2 that could be used for rate control. And those may be preferred if a patient has really severe uncontrolled asthma or COPD, because the beta blockers could potentially exacerbate those conditions. Finally, digoxin can also be used for rate control. However, it would definitely be your 3rd line choice. It's much less effective than the other 2 agents, and in particular, it's not effective for controlling heart rate during exercise. So certainly in active adults, you'd want to avoid using digoxin on its own. So it would usually be used as add-on therapy, and it may be beneficial if a patient has AFib and concurrent symptomatic heart failure. However, the AFFIRM trial did demonstrate increased mortality in patients that were on digoxin for rate control in AFib. So like I said, it's generally not your drug of choice for rate control, and for most patients, you'd want to look at whether or not they really need it, or if they could be maintained on a beta blocker or calcium channel blocker alone. So a target heart rate for rate control in atrial fibrillation is less than 100 beats per minute at rest. And so the RACE-2 trial found no benefit of stricter heart rate control versus more lenient heart rate control. And patients actually did better with more lenient heart rate control because they had less medication-related side effects. So a target of less than 100 is appropriate for most patients. So that kind of sums up our AFib discussion, and now we're going to move on to talk about heart failure in older adults. And specifically for this discussion, I'm referring to heart failure with reduced ejection fraction or systolic heart failure, so an ejection fraction of less than 40%. So there are 3 medication classes for heart failure that have demonstrated benefit in terms of reducing morbidity and mortality from heart failure. And so these are beta blockers, ACE inhibitors or ARBs, angiotensin receptor blockers, and aldosterone antagonists. So these are kind of your 3 well, I'm saying 3, I use ACE and ARB kind of as almost the same drug class. But these are your 3 go-to drug classes that patients with systolic heart failure should be on. And in particular, an ACE or an ARB and a beta blocker. We should really make every effort to have all heart failure patients maintained on these 2 drugs, because they've been shown to have the most benefit in terms of reducing mortality from heart failure. And aldosterone antagonists like spironolactone can then be used as an add-on agent for patients that are still symptomatic on maximized doses of your ACE or ARB as well as beta blocker. So all of this information at the bottom is contained in the Geriatric file. So initial doses of the ACE inhibitors, ARBs, and beta blockers, as well as then the target doses are seen on the next slide. So in terms of using beta blockers for heart failure, one key practice point is to wait to start a beta blocker until a patient is relatively stable with their heart failure. So you don't want to necessarily start or increase the dose of a beta blocker in a patient that's having an acute heart failure exacerbation. And that's because over the short term, it can actually cause decompensation of the heart failure. However, over the long term, beta blockers are beneficial both in terms of reducing exacerbations, hospitalizations, and deaths from heart failure. Monitoring parameters that are really important to be aware of for beta blockers would be heart rate and blood pressure, because they can slow the heart rate and as well decrease blood pressure. So it's important to keep an eye on those. ACE inhibitors or ARBs are your other go-to medication class for all patients with systolic heart failure. And so these medications you can start even during an acute exacerbation. They won't cause that acute decompensation that beta blockers can. Monitoring parameters, blood pressure, because they can lower blood pressure, potassium levels, because they can increase potassium, and serum creatinine as well. So quite rarely patients can actually have an acute increase in serum creatinine when starting an ACE inhibitor or an ARB. And if the serum creatinine goes up more than 30% over a baseline, then those patients likely can't tolerate an ACE inhibitor or an ARB, and you'd want to reevaluate that medication. The other key practice point to be aware of, and I'm sure most of you are familiar with this already, is that ACE inhibitors have been associated with causing kind of a dry, pesky, nagging cough as a side effect. And so when you're starting a patient on an ACE inhibitor, following up and watching for any changes in cough. It's a little bit tricky because heart failure patients might have a bit of a cough anyway, but any kind of worsening of that cough, you should maybe look at reevaluating the ACE inhibitor and switching to an ARB, because those medications don't have that same associated side effect, but otherwise work very similarly to ACE inhibitors. So now moving on to talk about aldosterone antagonists. So spironolactone, also known as aldactone, and eplerenone or Instra are add-on medications, like I said, if symptoms persist despite being maximized on your beta blocker and ACE or ARB. So you're going to want to titrate up those two medications first and then potentially look at adding on spironolactone. Monitoring parameters, so blood pressure and potassium levels. Potassium levels are really important because ACEs and ARBs can increase potassium, and now aldosterone antagonists as well. So keeping a close eye on that. And being extra cautious in renal impairment, because patients with kidney impairment also have increased risk of high potassium. So definitely keeping an eye on that. And then finally, loop diuretics, like furosemide or Lasix, are also used for heart failure, and they're used for purely a symptomatic benefit. So they're used to help with the fluid overload that can cause lower extremity edema, as well as cough or dyspnea in older adults, although they don't have any kind of mortality benefit like the other medications do. So in the ideal scenario, you want to titrate up your ACE inhibitor or ARB, as well as your beta blocker and perhaps your aldosterone antagonist, and try to minimize the dose of Lasix as much as possible to keep symptoms under control. Because Lasix also reduces blood pressure, we want to make sure that we have enough room in terms of the patient's blood pressure to use the other medications first. And sometimes that's not always possible. So monitoring parameters with loop diuretics, blood pressure, potassium, and actually the loop diuretics move the potassium the other way, so they decrease it, and serum creatinine as well to avoid any kind of a pre-renal failure. Using the lowest effective dose, like I already said, on an ongoing basis. However, the dose may need to be increased quite substantially if a patient's having a heart failure exacerbation. All right, so this keep calm and bang your head on the desk is kind of how I feel about digoxin in older adults. It's one of those medications that I think is really overused and kind of misunderstood, and we'll talk about why. So digoxin should be an add-on therapy if symptoms for heart failure persist despite optimized ACE inhibitor, ARB, beta blocker, and aldosterone antagonist, and then as well your loop diuretic for symptoms. So really, it should be kind of kept in reserve for patients that you're not able to get under control with those other medications. And that's because the tolerability of digoxin, particularly in older adults, can be quite poor. The maximum dose of digoxin for older adults should be the 0.125 milligrams a day, so any more than that predisposes them to digoxin-related adverse effects. Digoxin is very highly eliminated by the kidneys, and so you want to be extra careful in using digoxin in patients with any kind of renal impairment because it can accumulate. Signs of toxicity or digoxin adverse effects in older adults especially can be pretty nonspecific. So it can just be sort of feeling crummy, feeling a little bit dizzy, some balance and cognitive changes that can be due to thousands of other things in older adults. So in older adults on digoxin, kind of maintaining a high index of suspicion for potential digoxin-related toxicity and reevaluating that medication if possible in patients presenting with those types of symptoms. GI symptoms are also fairly common, so loss of appetite or nausea or diarrhea. And then if you're really getting to the toxic range, you can experience vision changes like halos around lights and that sort of thing, but that's not very commonly seen anymore. Okay, so it's the digoxin levels that sort of make me want to bang my head on a desk. So in the Saskatoon Health Region, the level is reported as being in the therapeutic range if it's between 1.1 and 2.2 nanomoles per liter. And really that's way too high for most older adults. So particularly in the heart failure trials, all the benefit of digoxin for symptoms is seen with a blood level between 0.6 and 1 nanomoles per liter. So for the most part, older adults with heart failure should actually be below the therapeutic range that's quoted when you get the lab levels back. For atrial fibrillation, if you do actually have to use digoxin for that, it's a little bit different because you're essentially looking to titrate to your target heart rate as opposed to any kind of specific level. But digoxin levels are not a target. So when you get the level back, it's not that you should be treating to that target level. So it's very different than level targets for medications like anticonvulsants or lithium or that sort of thing. Basically, digoxin levels are a tool to avoid digoxin-related toxicity, and that's all. So that's my digoxin rant. So again, keeping levels less than 1 for patients with heart failure is quite important, and especially older adults. Now moving on to talk about cholesterol medications in older adults. So we're going to focus on statins because they're the ones with the most evidence of benefit. And so what is the benefit of statins in older adults? Well, basically if they're over 80 and they've never had a heart attack or stroke or any event like that, we don't really know. So we're basically extrapolating evidence from trials of younger, healthier adults to older adults, which can be problematic for both tolerability as well as effectiveness reasons. So generally speaking, as patients are getting older and more frail and perhaps their life expectancy is a little bit shorter, then that's when reassessing the statin that the patient is using for primary prevention is probably appropriate. Older adults are more susceptible to adverse effects from statins. And again, statin adverse effects can also kind of mimic some of the other things that we see quite commonly in older adults. You know, like aches and pains and just feeling generally unwell and all of that sort of thing. So sometimes it's pretty hard to pinpoint the statin as being the cause of the problem. So in older adults that do have a lot of unexplained aches and pains and they're on a statin for primary prevention of cardiovascular events, it's probably a good idea to reevaluate that. Secondary prevention, so patients that have already had a cardiovascular event, is another story. So there is a meta-analysis that has been done of all the statin trials that have shown quite substantial benefits of statins for secondary prevention in patients up to 82. So that's kind of the high end of what we actually have evidence for. After that, again, we don't really have a lot of good evidence. However, because those patients are at such a high risk of a cardiovascular event, it is preferable to maintain them on a statin just based on what we know of risk reduction of statins in younger, healthier adults, unless you have a reason not to. Keeping in mind that the time to benefit of statin therapy is approximately 2 years. So starting or maintaining someone on a statin, you're probably not going to see the benefits within the first 6 months or even a year. It's going to be about 2 years out. So when we start looking at patients in long-term care type facilities or patients with really advanced dementia that have a life expectancy that is likely less than 2 years, then that's when reevaluating that statin, even for secondary prevention, is appropriate to try to reduce medication-related burden and optimize day-to-day function and quality of life. Moderate statin doses are preferred in older adults, and that's again a tolerability issue. So looking at your atorvastatin 10 to 20 milligrams a day or rosuvastatin 5, and trying to avoid wherever possible your big cardiology atorvastatin 80 doses, because those do increase the risk of those statin adverse effects that we talked about. So again, muscle aches and pains are kind of the most common, and usually that's what we call myalgia, so it's not associated with increase in creatine kinase levels and potential for rhabdomyolysis. That's just kind of a regular side effect that is nagging and probably won't necessarily get better. Mild GI upset is relatively common when starting a statin, but usually goes away once they've been taking it for a little while. Increase in liver enzymes is also fairly common, and unless the liver enzymes are getting more than 3 times the upper limit of normal, it's probably fine. Very rarely, initiation of statins has been associated with acute kidney injury, so being aware of and keeping an eye out for that. And as well, there are case reports of a reversible cognitive impairment developing in patients started on statins. And so this is usually seen within the first 6 weeks to the first few months of starting a statin. And patients develop what looks like a dementia, severe cognitive impairment, confusion, but it's reversible on discontinuing the statin. So also something to be aware of, it's not very common and I've actually never seen it, but it is a possibility. And so in an older adult that's recently started on a statin with a notable decline in cognition and function, it's worthwhile to try reevaluating the statin and see if that helps. And then again, if it's for secondary prevention and it doesn't make a difference, then probably putting it back on is appropriate. So other cholesterol medications like ezetimibe or Atrial, fenofibrate, niacin, we're not going to spend any time on because that's about as much time as I think they should be spent on. In older adults, I would reevaluate those medications. They don't have a lot of evidence of benefit, and side effects, drug costs, and drug interaction issues, I just wouldn't really bother. So statin or bust, basically, for cholesterol medications in older adults. So we're not going to spend a ton of time on medications for stable coronary artery disease because these medications are very similar to what we've already been speaking about. So for stable coronary artery disease, I'm talking about stable angina, patients that have had a prior acute coronary syndrome or a previous percutaneous coronary intervention or CABG. So those patients all have coronary artery disease. So in assessing the appropriateness of medications, it's important to consider the time since event. So we've already talked about that in relation to aspirin. So for patients with AFib, if it's been more than 1 year, then warfarin alone is sufficient. However, for all other patients with stable coronary artery disease, they should be on aspirin lifelong. So unless they're on some other form of anticoagulation, aspirin lifelong is important to help reduce the risk of cardiovascular events. As well, having a look at symptom stability. And by symptoms, I'm generally referring to angina like chest pain. So if patients aren't having that, then it is possible to back off some of the medications for stable coronary artery disease, and particularly if it's been more than 3 years since an event. So evidence of beta blockers for secondary prevention of cardiovascular events goes up to about 3 years. And then after that time, we don't really have a lot of evidence supporting the use of beta blockers for secondary prevention of cardiovascular events. So it is possible to reevaluate beta blocker use in patients that aren't having a lot of angina or chest pain-like symptoms that we'd be worried about. And then, of course, considering patient goals and preferences, as always, when looking at these medications. It's also important to be aware of that as adults age and become more frail, and activity levels decrease, medication requirements for symptomatic management of stable coronary artery disease might decrease as well. So you might be able to back off of things like a nitroglycerin patch or, like I already said, a beta blocker that patients are on to prevent chest pain if they're no longer as active, and particularly if they're having side effects from those types of medications. So medications that can help to reduce angina like chest pain. So beta blockers, like we've already talked about, and calcium channel blockers. And all calcium channel blockers, so including amlodipine, the dihydropyridine calcium channel blockers in this as well. Generally, beta blockers will be your first line for reducing chest pain in patients with stable coronary artery disease. I'm going to talk a little bit more about nitrates because we haven't spoken about them at all yet. So all patients with stable coronary artery disease should have some kind of nitroglycerin short-acting, like either spray or tablets, for managing acute episodes of chest pain. As well, some patients may require a long-acting nitroglycerin formulation if being on a beta blocker or calcium channel blocker isn't sufficient to keep their angina under control. So most common would be a nitroglycerin patch. What's really important to be aware of with the nitroglycerin products is that tolerance develops if they're used continuously. So patients require what we call a nitrate-free period, or a period of time where they don't have nitroglycerin on board at all, of about 10 hours a day to prevent that tolerance from developing. So patients should either wear the patch during the daytime if that's when they have symptoms, or occasionally at night if that's when their symptoms are worse, and then have the patch off for the remaining half a day to prevent that tolerance from developing. Nitroglycerin adverse effects, pretty common headache and dizziness. As well, nitroglycerin can reduce blood pressure, so that's important to be aware of, and particularly when combining it with other medications that also decrease blood pressure. Nausea and flushing are fairly common as well. And so nitroglycerin, and particularly nitroglycerin patches, are one of those medications that it's often beneficial to reevaluate in older adults that, again, maybe are getting more frail, their activity levels are declining, and perhaps they don't necessarily need the same dose of a nitroglycerin patch as they did 10 years ago, and it may be causing undue reductions in blood pressure, which I think is probably the case with Mr. HN, as we'll go back to in a few minutes here. Other medications for cardiovascular risk reduction, so again, aspirin lifelong, unless they're on some other kind of anticoagulant. Statin, again, usually lifelong, like we already talked about. ACE inhibitors, or ARBs, are recommended for all patients with stable coronary artery disease, and particularly those that also have hypertension, diabetes, heart failure, chronic kidney disease. So that will be most of your patients with stable coronary artery disease. And beta blockers, and for sure beta blockers for the first 3 years following a cardiovascular event, or for patients that have ongoing problems with angina. And then other medications may be required to control blood pressure. So now we're going to move on to talk about hypertension in older adults. So what we usually see is isolated systolic hypertension in older adults. So high systolic blood pressure and relatively normal to low diastolic blood pressure. And this is due to increased stiffness of the large arteries that happens with aging. Some important physiological changes include reduced baroreceptor response and impaired cerebral autoregulation of blood pressure, predisposing older adults to things like orthostatic or postural hypotension. So it's really important to avoid overly aggressive and quick reductions in systolic blood pressure. So the old adage to start low and go slow is really important for blood pressure management in older adults. Target blood pressure in older adults. So the 2016 Canadian Hypertension Education Program guidelines recommend less than 150 on 90 in adults 80 years of age and over. However, recently the SPRINT Elders trial was published, and so that's a sub-study of the original SPRINT trial that looked at more intensive versus less intensive management of blood pressure control, so a target of less than 140 versus a target of less than 120. Exclusions from the SPRINT Elders included patients with diabetes, heart failure, a history of stroke, or a blood pressure less than 110 after 1 minute of standing. And so those are really important to be aware of, and so those patients were not included in this sub-study. And they actually found pretty important reductions in cardiovascular events and cardiovascular mortality for patients in the more intensive blood pressure management arm. They also found actually not a lot of difference in side effects either, which was a little bit unexpected. The only thing that they did find that was actually significant between the two groups was the risk of having an increase in GFR decline, which is kind of confusing, but basically not end-stage kidney impairment, but just patients in the more intensive arm were more likely to have some evidence of kidney decline over the trial. So that kind of threw a wrench into the whole blood pressure target for older adults that we've been talking about for the last several years. So now what should we do with this information? I think there are several things to consider when applying the evidence from the SPRINT trial to your patients. And so the first is, like I already alluded to, the exclusion criteria. So patients with diabetes, heart failure, stroke, or systolic blood pressure of less than 110 on standing were not included in the SPRINT trial, and so results of the trial are not really applicable to those patients. As well, of course, being patients in a clinical trial, they had really structured, really thorough ongoing monitoring and follow-up. So if you are looking at targeting a more intensive blood pressure control, making sure patients are willing and able to come to the office more for appointments and making sure that their blood pressure is controlled at a safe level if you're going to be going to more strict targets. Tolerability issues as well. So patients in the more strict control arm usually required at least one more medication to get blood pressure under control. So patients also need to be prepared for that and any related medication side effects. But I think the SPRINT trial does give us a little bit of comfort in older adults that do have a lower blood pressure that's below the 120 that maybe we would be more concerned about before the SPRINT trial, as long as they're tolerating that lower blood pressure well. So they're not dizzy, they're not experiencing falls or anything like that, and they're tolerating the medications well, then it's probably fine to continue on with the lower blood pressure target, and they may actually be getting some benefit out of that. So I think it was reassuring from that perspective. And as well, in carefully selected older adults, it is reasonable to target a lower blood pressure if that's what the patient wants. So again, those patient preferences are paramount. So I'm not going to spend a ton of time on the medications for hypertension just because we've already covered them in the various other topics. But the Canadian Hypertension Education Program guidelines are a really good resource for this. And this information is in the regular RX files and the Geriatric files as well. Medications to avoid as antihypertensives in older adults. So beta blockers, if a patient doesn't have any other reason to be on a beta blocker. So beta blockers just for high blood pressure shouldn't be your go-to choice. And that's because they're just less effective at actually lowering blood pressure in older adults. As well, medications like clonidine or methyl-dopa, some of your older antihypertensives, are not as well tolerated in older adults, and so it's recommended to avoid those and go with more of your first-line medications wherever possible. So just a quick note about orthostatic hypotension, or a drop of more than 20 systolic or more than 10 diastolic when a patient goes from sitting or lying to standing. Orthostatic hypotension is an important risk factor for falls and hospitalizations and also even cardiovascular events. So it's important to check for a postural drop, and particularly in your frail older adults. So a lot of the comorbidities that would particularly be seen in long-term care increase the risk of orthostatic hypotension as well. If a patient does have orthostatic hypotension, then you may actually need to back off on their blood pressure medications in order to close that postural gap. So being very careful with that. And again, noting that the SPRINT elders did exclude all patients that had a low systolic blood pressure on standing. So we wouldn't apply the results of that trial to these sorts of patients. So questions that remain from the SPRINT trial: how low is too low for blood pressure in older adults? There's no easy one-size-fits-all answer, and I think that basically just depends on your patient. So how well are they tolerating the various blood pressures, and then making sure that, again, medication side effects and that sort of thing are minimized. And as well, diastolic blood pressure. So we don't have any medications that specifically target systolic blood pressure. So all antihypertensives will lower both systolic and diastolic. Which again, because older adults may have normal to low diastolic blood pressure, is important. And how low is too low for diastolic blood pressure, we still don't really know. We do know that low diastolic blood pressure can actually contribute to angina like chest pain due to reduced coronary perfusion, but what exactly that number is, we don't really know. But my advice would be, if you have a patient that's in that situation, so has a quite low blood pressure and they're having chest pain, then look at backing off the antihypertensives a little bit and see if that helps. And if it does, then you know that the diastolic was probably too low for that patient. All right, so now we're going to go back to Mr. HN and resolve his case. So you'll recall, I'll give you a second to just kind of look over some of the details of him here and start thinking about how you would answer some of those questions now that we've reviewed these medications. All right, so now we'll kind of go through the issues one at a time. So for atrial fibrillation, does he require warfarin, aspirin, or both? I hope you all feel like you know the answer to that now. So for him, it's been a long time since his event, and warfarin alone should be sufficient. Would a new oral anticoagulant be better? So some things to consider with him are, of course, his kidney function would be the biggest one. His kidney function is pretty borderline, and you want to be careful with starting an agent that you may then have to go back to warfarin in a few months or whatever if his kidney function declines further. So what I would want to know to answer this question is, how well is his INR controlled? If his INR is quite stable on warfarin, then I think it's a pretty easy decision to leave him on warfarin. If his INR is really fluctuating, then the decision becomes tougher, and that might be a discussion with the patient individually. Are both bisoprolol and digoxin needed to control his heart rate for AFib? So his heart rate right now is about 53 beats per minute, so it's pretty low considering our target heart rate is less than 100 for patients with AFib. So looking just specifically at the AFib, I'd say no, he doesn't require the digoxin for that indication. So now looking at his heart failure, does he need digoxin for heart failure? And this is a little bit of a tougher question to answer because we don't necessarily know if starting the digoxin helped with his heart failure symptoms at all. The first thing I'd want to do is check a level to make sure it's within that safe range that we talked about, the 0.6 to 1 nanomoles per liter that's optimal for heart failure specifically. And with his crummy kidneys, I'd bet that it's not, and it actually wasn't. So his level was 1.6 when we checked a trough level for digoxin. So we cut back the dose to 0.0625 milligrams a day for a couple of weeks. And then at that point, he really hadn't noticed any change in his heart failure symptoms. So we decided to try stopping the digoxin to see if it affected his heart failure symptoms at all. And if it did, we would put it back on. But in this case, it didn't. So we just left the digoxin off, and he was able to just get rid of that one medication. Hypertension. So is he on the right combination of medications for his hypertension? And I would say yes, his medication cocktail for hypertension looks pretty reasonable given his history. So he's on the beta blocker that we'd want to see for both heart failure and potentially coronary artery disease. He's on the ramipril, again, that we'd also want to see for both of those indications. And he does have furosemide on board to control some of those heart failure symptoms, which isn't a medication specifically for blood pressure, but needs to be there for other reasons. The one thing that I would wonder about is his nitroglycerin patch. So he's on a pretty hefty dose of the nitroglycerin patch at the 0.8 milligrams per hour. And so what we decided to try to do was to titrate back that nitroglycerin patch a little bit. His blood pressure is super low, and we were a little bit worried about that, and whether he's one of those patients that perhaps the low diastolic blood pressure was contributing to some of his chest pain issues and things like that that he was having occasionally. So we cut the nitro patch back very slowly. We went first down to 0.6 for a week, and then down to 0.4 for a week, and then down to 0.2 for a week. Very gradually, his blood pressure started to come up, and he noticed no difference in terms of his chest pain or other symptoms like that we'd be worried about. He wasn't having to use his nitro spray anymore, and he was actually starting to feel a little bit less dizzy, which is not unexpected when you actually have some blood pressure. And so we discontinued the nitro patch, and he did just fine. So again, he's probably one of those patients that required it at one point in time to help manage his symptoms, but because he's older and a lot more frail and his activity level is pretty minimal, we were able to stop it slowly, of course. How low is too low? Again, we don't really know, but it seemed like for him that blood pressure was too low, so we cut back on that. And then finally, for his high cholesterol, at 93, does he still need a statin? And so certainly, again, this is kind of a judgment call. And this is basically a discussion that we decided to have with the patient individually. We talked about, benefits in up to 82, and I mean, he's 93, so he's well out of that beneficial range. But he decided he felt like he was tolerating it fine, and he was perfectly happy to stay on his statin for cardiovascular events. So we just left that one alone. But yeah, so that kind of wraps up our first patient case and some of the issues with managing cardiovascular events in older adults.